And I would like to introduce Dr. Mike Leibridge. He is joining us. Good morning, Dr. Mike. How are you today?
I'm wonderful. Thanks so much, Christine. Nice to see you.
Nice to see you again, too. For some of you, you may remember that he joined us in the spring, and we must say that he was a very, very popular speaker then, and we're so excited to welcome him back. Dr. Leibridge is an associate professor in the departments of urology and oncology at Queen's University and is the residency program director for the urology training program that Urology Always Gets Me. His clinical focus is urologic oncology in addition to a general urology practice. And he's going to speak to us today on steps to diagnosis and follow-up. It's always frightening to get that diagnosis, so I'm going to let you take it away and ease our minds. Thank you.
Thanks so much, Christine. It is my pleasure. I've been scanning through the agenda on the webpage, kidneycancerforum.ca, and over the course of the weekend, a rarefied company that I'm thrilled to have the chance to be a part of. I'm going to sort of give an overview that sounds like some good deep dives into some therapeutic stuff later on, as per the theme of today, from diagnosis through management. And this is going to be sort of a high-level overview. You might almost see it as the kind of the spine of a fishbone with all these branches, and each one of these branches about all the things we can talk about: the diagnosis, the wait times, the management of your individual disease and the individuality of your disease. These are all topics that could be full conferences and sessions, let alone. But I'll do my best to give a bit of an overview and then a few little deep dives into some of the the man behind the curtain, Wizard of Oz stuff, where we're all just kind of people trying to navigate our lives, patients, caregivers, advocates, and physicians. Give a little bit of the behind the scenes into what we're thinking and to how you may approach learning the basics of your disease to give yourself that scaffold and expectations, as well as what it means perhaps from our side to force a wait time on you, what it means to be in the clinic with each other, sharing us learning about you and your values and your understanding of the disease, and us trying to impart our quote unquote wisdom, which of course goes nowhere without being put in the framework of your own values. So I'm going to share my screen here. This is sort of the name here, Navigating a Diagnosis. We're going to talk about a few things as we go through, including the surveillance of the disease after diagnosis. And one of the great themes, of course, is that when left to one's own devices and thinking, this is where some of the anxiety can be. And so hoping to allay a little bit about that. Again, my name is Mike. I'm a urologist here in beautiful Kingston, Ontario. Should be on your itinerary whenever you choose to open up, or whenever the world opens up for us. I have no relevant disclosures to discuss about today from a pharma or other conflicts. I'm just happy to be a part of the Kidney Cancer Canada community and have been for several years. And it's been a highly valuable thing for me. This is today. So we're going to talk about the real, where does it begin? And all I can do is hypothesize about what people are going through. I mean, we all know our own medical lives, and from the kidney cancer perspective, we're really going to talk about what does it mean to find your way to us as the urologists, and to find your way into a world where you are a quote unquote kidney cancer patient, and then move from there. The clinic visit really is the first encounter for yourselves as patients, caregivers, advocates, with the team who will tell you the most they can about the disease, put it in the framework of yourself, and try to devise a plan for management and surveillance down the line. This is where the maximum information density is, and I hope the point where a lot of the anxieties around the situation become more understood and allayed. I'm going to briefly talk about this theme of knowing your disease as well. Knowing your disease basically means that, as Christine pointed out earlier, and as many of you know from learning about your community, kidney cancer spans a shocking breadth of disease. The word cancer carries its certain freight with us when we hear it, but boy, the differences in thinking around a small isolated kidney tumor all the way to somebody with disease that has escaped the home base and spread to other parts of the body. Those are extremely and exceptionally different ways of managing and understanding the disease. So trying to figure out where roughly you belong in that framework, understanding that these are not towers and silos separate from them from each other, but really a bit of a spectrum. And this hopefully allows you to somewhat set expectations about how you are being understood and how management recommendations are being made in your case. And when those don't align with what your expectations are, the ability to sort of recognize that with what I'll call your spidey senses later on. And then we'll talk about these terms: surviving, survival, survivorship. At its root, it carries the sort of heavy weight of what a cancer diagnosis means to any of us, and that is prognosis, that is managing the disease and what the future holds for us. But there's a lot of living in these disease states, and it's testament to the people here watching and all the people you've cared for that life with a kidney cancer diagnosis carries on. And we have to be able to think about what life should look like during there and what our expectations might be. This is called survivorship, something that really didn't get a lot of attention in decades previously, but all those moments when you and those you care about are left to think about your disease and left to see the calendar that shows the CT scan or the appointment or the surgery date or the time in the immunotherapy chair and the feelings that wells up inside you. That is what survivorship is. And I think understanding a little bit about those expectations can go a long way to normalizing and allowing a life to begin apace. So let's dive in. How does it begin? It oftentimes begins with just a feeling. We know ourselves and we know when something is not quite right about the way we're feeling. And that can be anything. That can be a pain that we haven't recognized before. That can be something as stark as blood in the urine. That can be a feeling of a lump somewhere when you're just lying in bed. That can be a vague sense of unease. It can actually be something completely unrelated, like a gallbladder attack or maybe an appendicitis or even constipation that leads us down a path that leads to somehow coming to understand that there is a problem with our kidney related to a tumor. This is a zone of anxiety. This is a zone where we hope people are attentive to their bodies and then seek out somebody to try and put this information into context. And this is usually the primary care provider. Oftentimes, this is an urgent care provider or even an emergency medicine provider. And this really is a place where some people can be facing their symptoms and allowing all these sort of internal mental processes to prevent them from seeking this care. So step zero in everything is that very important bridge between feeling unease and addressing unease. So bringing oneself to the primary care person. And then what happens then is that primary care person or the emergency person takes this information into account, comes up with a first steps management plan, which inevitably leads then to here. And you don't have to interpret a CT scan. I can promise you that there's a small tumor on the patient's right kidney on this CT scan, but it could be any version of a diagnosis. We're still surprisingly in a relatively low information zone. And this is an example where a bit more information can sometimes be more anxiety producing. A vague set of symptoms, a sign like blood in the urine, and as I say, again, something totally different, like a feeling of pneumonia that catches something on an X-ray or an ultrasound. Suddenly, a face appears that says there's something wrong with your kidney, or there's something in your lungs, and we think it belongs to your kidney, et cetera, et cetera. And now we've got, at last, the image resolving of what may be happening here and a place to start moving forward. This is the zone here, this diagonal line between this CAT scan and this doctor's bag, where I, as a urologist, and my colleagues as urologists, medical oncologists, radiation oncologists, interventional radiologists exist. We're not up here in the zones where we don't know how things are going, but here's the specialist visit. And here's what we're going to talk about in some detail. And this is basically us saying, this is the situation as we know it. These are our expectations around how things are in your situation right now. Let's put them in the context of you as a person, health-wise, values-wise, come up with a plan and start to manage. In an ideal situation, that management enacts, and we convert the person with a vague sense of unease, then the person with something wrong with my kidney, to a person with a plan, to a person with a management strategy that leads them forward. Sounds pithy, sounds nice. This is an overarching theme of how these things happen. But of course, the intervening thing is that there's weights. Every one of these times has a weight, and every weight has an anxiety associated with it based on how much information is known and how much actual suffering may be going on in the physical realm. We can talk about weights in the abstract, or we can talk about weights in a little bit more specific detail. And as we get now coming at you from the urologist's level or the practitioner's level, we can actually name these weights. I should say there's a weight X that, as I described before, would be the fact that some things just get put away and don't get brought to anyone's attention. But weight 0 is the first name we call this. And this is when you have made the reach out, or someone has made the reach out on your behalf to figure out what the heck is going on with them and why they're feeling or experiencing what they're experiencing. This is a zone where we know something's wrong, but we don't know what or anything. And this is a place where we actually feel a bit of relief because the doctor's appointment is coming up. But if we feel a certain amount of anxiety about this, that time to the doctor's appointment can be very anxiety inducing. And I will say, from our angle and from the primary care angle, there is a triage situation. The information we get allows us to think about our version of an urgency, which is abstract in terms of safety for the most part, and then put people on a list to be seen. There's a big gulf between what a physician considers urgent and what a person experiencing things considers urgent, and that is an important thing for us to experience and understand about each other. Weight 1 is the next weight. Weight 1 is when you're waiting for that consultation to the specialist. At this point, you've had that ultrasound, perhaps you've had that CAT scan, and you understand that there's something wrong, and it's something that seems to be arising from or involving your kidney in this context today. Then the referral goes into the specialist, and that specialist could be a urologist, overwhelmingly, could be a medical oncologist in some circumstances as well. Now, this is what I would probably consider the lowest combination of information to anxiety. Now someone has told you there is specifically a problem. What you felt as an unease, what you saw as a symptom now has a truth to it and has a name or a face, but that face isn't quite resolved. You're looking at it through no glasses and trying to figure out, what sort of threat index is this? I know someone told me there's a shadow on my lung. There's a dark spot on my kidney. What the heck does this mean? This is why I mean low information, even though it's more information, but high anxiety. This is the point where every other ache and pain, every headache, every twinge in the side, every toenail burying into the skin is somehow attributable to this problem, because it can start to spiral and feel like, okay, I've got a thing, I need to do this. This is the most sort of tortured weight, I would say. This is what urologists are seeing. When we see a referral saying renal mass, we think about it, we look at it, we put somebody into our priority list, and I'm using air quotes here because it is nothing to do with a person's experience of this, but a priority list to get people in and seen. Then there's weight 2, and weight 2 is not for everybody. Weight 2 is for those who are going towards a surgery. Surgery is, as I say, not for everyone in kidney cancer. We'll talk about circumstances in which we would simply watch the disease and monitor things quite safely. We'll talk about times when surgery is not indicated because other treatments are likely the best bet and bang here. This, of course, is associated with hopefully some relief because the process has a name, has a face, and we're moving towards an end goal. But boy, that end goal of a surgical management can seem like a mirage that never seems to get closer until it's right upon us, which is a different set of feelings. So we quantify these things as well with our priority lists. And again, I'll say it till I'm blue in the face. Priority simply speaks to a version of staging how soon someone should be seen based on a perceived threat to life and limb. It is not about importance per se in the person's life. And this goes from priority ones, which are considered get thee to the hospital and be managed within the next 24 hours. Blood that's preventing someone from peeing, or making someone need a blood transfusion, somebody with severe pain, for example, all the way to something that is perceived as a smoldering event that is unlikely to bear negative fruit in the next long while. And so this person can be allowed to wait at some duration of time. And we have targets for these things. Weight 1 and weight 2. Remember, I said weight 1 is that low information, high anxiety zone. We actually have numbers that are associated with these things. Weight 1s priority 1s tend to be 24 hours. Priority 2s, 10 days. Priority 3s, 21 days. Priority 4s, 35 days. These are the targets. And in Ontario, we're about 2/3 to better than 3/4 on those, and usually not great expansive waits longer than that. We hope. Some of you may have experienced something longer than this. And then on weight 2s, which is the time to get to surgery, it's a different set of numbers that extends out as far as even 6 months, sometimes for things that are considered less threatening. We're slightly better at getting people managed on those timelines. Again, this is all in the abstract. The person who's experiencing this, boy, would it be nice to have problem turn into image, turn into consultation, and turn into plan, turn into management over the course of 24 hours. We see this in some spaces, breast cancer clinics, for example, that are all in one stop from mammogram through to pathologist report. It's aspirational and balanced with resources, balanced with safety needs, and certainly minimizing these things is a vision statement and a goal for all of us. Let's get ourselves into the clinic. Now, this is the moment where hopefully the swirling of information and anxiety can come out, the information exchange from the quote unquote experts who put the context of the disease, its anatomy, its risk stratifying, which is the danger level we see, into the questions, the values, the hopes of you or those you are caring about. And in the clinic, we wish to answer your questions. Answering questions hopefully implies coming with some questions. And you don't have to come with questions. You can come with caregivers. You can come with a blank slate and get information. Sometimes that's the best way for you as a person to manage this. Sometimes it's a more fastidious approach where Dr. Google or Dr. Introspection comes out and the list of questions flows from that. Very brief aside on Dr. Google. It's good. It's good to go looking things up on the internet. We don't have great information guaranteed for people on the internet. People you know, your clinicians will sometimes be able to guide you to places that are a little bit more efficacious. And I would consider it a good place to gather sort of a low resolution bit of data. But boy, when you have a term like kidney cancer or tumor mass, you're going to find a huge breadth of information. And the large majority of it will generally not be applicable to the silo that you're going to be in, which we'll discuss a little bit later. So I consider it a great place to gather a gestalt set of information about things. And if I had any general rules about vetting whether something is reliable or unreliable, if somebody's telling you specifically what you need to do, not knowing anything about you, you can probably decide to be a little bit more specific or suspicious about that piece of information going there. If it's a bit of vague information or a bit of classified information, as in classification, you can be a little bit more trustworthy. Nobody should be telling a stranger what the answer is and what to do. And if they are, they're likely trying to sell you something. And that applies to the broad spectrum. If it has terms like things they don't want you to know and stuff like that, I would just say they may be right, but they're probably not. And these are places to raise your suspicion when you're online. But online is good. Getting information about yourself is good. It's just about understanding how deeply one ought to trust the veracity, the truth of that information. Bringing in reams of paper and thoughts as well is something that you can put together in your mind and have a bit of a constructed way if you choose to be that way. As I say, coming in with a clean slate and just saying I'm here for information is totally fine. Everybody's different on the inside. What you hope to get out of this information is the details of your situation, your cancer, put in the context of you. We'll have some information about your cancer based on what we know about these disease processes, based about the established treatments and expectations around it. But you're the person who this has to happen to, and whether that meets with your values, your hopes, your expectations, what you know about this from other people, that's the important thing. We'll talk a little bit about that in a few more minutes as well. And what you hope to leave with is a plan. A plan may not be a solution, but a plan means here's the situation as it's going to unfold from here. That has a huge amount of anxiety allaying power to know that things are laying out in front of us. The swirl of information rendered into a page or rendered into a calendar has a very powerful soothing effect on at least knowing that the wheels are turning, people are thinking, we're heading towards some sort of resolution, whether that's wait two for surgery or a move forward to further investigation. So when you bring your questions, as I say, one of the things to consider here is, two modes of being. And these are foundational to the sort of doctor-patient communication. One is to come with your list of questions, great, and then articulate that list of questions. That is good because those are your questions that you wish an answer to. Those are also going to be great for your memory, because if you ask the question, when you get the answer, you're going to remember this very well. Now, it may also be that your list of questions may not be organized in a way that's perhaps the best way for you to understand this disease from the bottom up, or in a way that's going to be a little bit confusing, but it's still a good way to go. Another way to go into clinic is to say, here's what I know about my situation so far. And then the caregiver, the clinician, the urologist, the medical oncologist, then runs through what they know about you. Here's what the referral said. Here's what I see on the imaging tests and the blood tests or whatever we've got so far. Here's what I think the situation is. And here's what our normal suite of management or surveillance strategies are. You tell me what you think about what I've told you, and let's find this ground and make a plan. Those are two excellent communication strategies. Each one is for a different type of person. I often use the term in clinic, parallel universes, and I say to a patient, if there could be two versions of you, one person who just wants to get the information that they've come in here and scratch that itch, the other person who wants to absorb the information and take it down and then reflexively ask questions. Both are totally fine. It's the tapestry of how our minds work. Bringing your friends, your family, your advocates, your phone. These are all important things. And boy, it's a bit stranger in 2021, 2020, and probably into 2022 when visitor restrictions are in effect. I'm of the opinion that having a fair number of people in the clinic is great. There is a number at which things are going to dissolve into talking over oneself, but having an external brain, I think, is a wonderful thing. In general, we should all have a pen and a notepad around to scratch these random thoughts. I find myself in the shower wishing I had my phone with me when some inspiration strikes, and I'm sure you felt the same. Putting these questions down very slowly as you go, bringing other people who are invested in you, but not as fully emotionally invested in the situation, can be a good way to have somebody sort of soberly writing down information while you bounce things off your own psyche and your own values. It provides the sort of the best of all these worlds. The phone has two modes here. The phone can be the way we actually communicate. In our cancer center, we don't always have people in there. And so I've spent a lot of time yelling into somebody's phone while I'm talking to the patient, and that provides somebody off-site who can have all the paper and pens in the world that we can't supply at the cancer center, taking information down. The other brief aside on this is recording conversations. You're going to meet with a bunch of different thoughts on the value of recording conversations with doctors. I don't think most physicians think it's super highly valuable, but I don't think most physicians are very upset about it. I think as long as we know it's happening, that means that we're all on the level and being fully honest with each other. Surreptitious recording isn't wrong in its own set, but it just doesn't feel like the trust and the bond is met between two. I like to know that I'm being recorded because I actually sort of change the way I talk. I probably articulate things a little more slowly. I may rely a little bit less on the critical nonverbal information, because if I've got to assume something's being recorded, then the looks on the eyes, the nods, the the body language, the leaning, these things are lost from that. And so it may be a little bit less of an emotionally back and forth discussion, perhaps a little bit more of a rote, organized discussion. Benefits to each. And as I say, most of us don't particularly mind that situation, but your mileage may vary. You may have a physician who feels that this is intrusive. And I don't necessarily think that's wrong. And your personal information needs as well. There are infovores out there who want to get all the information they can about something. That's good. It can be counterproductive when the desire for information is never sated and people feel like the next piece of information is going to be the critical thing to scratch that itch of understanding. But for a lot of people, it's just about getting as much information to feel informed that you have the toolkit to make the decisions for you. Remember, these are all your decisions, and you don't want to make them in an information gulf. You want to feel at the end of that appointment that you know enough for now to move forward wisely. Some people come into the clinic and say, "You're the expert, doc. You just tell me what's up." None of us really likes that. Maybe some people do, but I don't want to know them. But most of us prefer the sort of give and take. Here's what I think about this, and here's where this fits with my expectations and values. And we're happy to be information fire hydrants, and we're happy to be conversive as well. So your own information needs is probably the most important thing. And everybody comes with what we call preformed antibodies, which is our sort of pithy way of saying, on the spectrum of decision A to decision B about managing somebody's disease, everybody actually rolls in somewhere. Everybody has a leaning or an orientation, whether they know it or not. People will come in, and when you mention something like surgery, they'll immediately bristle. That's important information. The other person, again, the parallel universe person, may say, remove this at all costs. And that's my baseline start. It's important to sort of know where you fit on the map, the playing field of anxiety, of acceptance of certain treatments, of your desire to be informed, because that will help shape the conversation to be more effective for you. Before we move on to the disease itself and close things out, I guess the question here will be the issue of the second opinion. And this speaks to that knowing your information needs. This is a niche thing. I do not believe that everybody ought to have a second opinion. If you feel satisfied with the interaction, if you feel that the interaction was respectful and the information you've got is good for you, you've done your job. And the majority of times, a person you will be sent to will be, quote unquote, the right person for the job. And in other times, that person will know the right person for the job. But mismatches happen. Mismatches of expectations, mismatches of information transfer, and referrals that just happen because I happen to be on call this weekend and I'm going to see somebody for this next week, because that's what happens when you're on call. And recognizing when those mismatches occur is where the second opinion idea comes from. And a second opinion can be great. A third, a fourth opinion can be great. Starts to get into information overload, as I sort of intoned before. More information is not always better. I had that line actually told to me explicitly for the first time, and not in the abstract, when somebody who was in the prostate world said, more information is always better. And that's not always true. More information implies more weights. It implies information on the same theme that doesn't necessarily align perfectly from what you remember a different person saying. That can create some confusion, that can create some resentment. And sometimes, based on these preformed thoughts we may have, we're just waiting to hear something. We may have something where 7 people would say, this is the correct management strategy. And the 8th person may say, well, of course, we should do this instead. And if that's what you're waiting to hear, that's going to feel great, but it may not be the best thing. So there is the mathematical concept would be approaching the asymptote. There is a point where the return on investment of more information is likely less useful. But in general, you want the information you need to feel informed, to make decisions that fit best with yourself. Expertise out there. Urology is not a million doctor community. There are about 800 of us in the entire country. Our networks are small. We know people just about everywhere, whether you're coming from a smaller rural area with a single solo practice practitioner or a major urban center with a university practice. People know people in this urology world. It's one of the most wonderful things about our Canadian Urologic Association is that it's an incredibly tight-knit, surprisingly small group. It may feel like the best move to say, I want the person who's done the most of this in the country. That person's going to be super busy, and that person may not necessarily always be the best person. There's a huge group of excellent practitioners in this country on all aspects of kidney cancer, whether they're the medical oncologists for the disseminated or metastatic disease, whether they're the surgeons for the surgical management of the disease. Getting the sense from that visit that you're in the hands of a person who has experience, expertise, which are two overlapping but not exactly the same things, who understands your disease in your context and helps you make decisions is the right move. And to that end, arriving with good faith, understanding that you're probably seeing somebody who knows the score in this situation. They may not end up being your surgeon, but they ought to be the person who sends you to that person. They may not be your medical oncologist, but they'll have colleagues in that center or in that setting for the most part. And we are the same. We have to go in there knowing that we are seeing people who are seeing us for their reasons, and we have to know ourselves whether we're the correct person for the job. It helps to understand that you're probably going to see a person who knows the score and arrive similar like that. I keep saying to that end, of course, but there's always a but. Your spider senses I referenced earlier. Spider senses are just that sense that this interaction doesn't feel like I'm achieving what I want to from that interaction. It can be a personality mismatch, can be an information mismatch. Occasionally, you will find someone who thinks this is the answer, this is what we've got to do, and take it or leave it. That doesn't feel great to most people, and mercifully, most people from our urologic world aren't like that. And from my 12 years of experiences in practice and years before that in training, from your end, patients are always quite reasonable by default. And so the mismatches are rare, but you feel it when it comes up. It just feels sort of out of sync. It feels like you're being fed information without being able to sort of feedback or without having the feeling of understanding of yourself. Hostility is rare. And that's the red flag. And if somebody you feel is talking down to you for some reason, if somebody is talking over you for some reason, if somebody is dismissive of which you feel to be important, those are just the red flags. I hope most of you haven't had that experience deeply, and I hope that it's mercifully rare within our environment. I told myself here that I would have a little note on telehealth as well. Telehealth is basically moving the clinic visit inside the telephone rather than getting in the car and coming down. Urologists, practitioners of all stripes want to see people. We may be able to look at a scan and go 80% of the way to saying, I think I know what the move is here. But it's critical to be able to look people in the eyes, have conversations with these nonverbal elements, sometimes do what we call the hallway test. Just gives us a sense of medical fitness and wellness, what surgery or medicine might look like or feel like in a person. That's important, and it's information we can't necessarily get over the phone. That said, lots of surveillance, lots of follow-up. These can be things that really didn't ever need you to jump in a car and drive 150 kilometers to hear the report of the CT scan you had 100 kilometers away 2 weeks ago already. So mixing these things up, I think, has been a real intervention. So in short, you want surgeons, if you're in the surgical realm, with experience and expertise, people who are learning, people who are doing. But a lot of what comes out here in your successes and your feeling of being part of a team is the multidisciplinary team. Having nursing expertise, ward expertise, medical or local radiation oncology expertise, having a group of people who talk about cases with each other is an important thing. And that's a lot of the support, a lot of the navigation that comes along with this diagnosis down the line. All right, this is the only semi-gory picture, and I hope it's not gory. On the left is the CAT scan I showed you at the very start. It's just a little tumor. And when I say just a little tumor, That's the glib interpretation of a urologist seeing a situation that I feel doesn't necessarily pose a huge threat to someone. Nothing to do with that wait 0, wait 1 time when somebody knows that something is amiss. The disease can also be advanced. This is a larger tumor on a kidney with some disease in the lymph nodes. We're going to get to the idea of knowing your disease so you can sort of have a sense of what is congruent with your expectations and what is out of sync. These are going to be some of the discussions you're going to have later on today, so I won't go into the weeds because, boy, every one of them is a topic of a career, let alone a talk. We think about disease as basically where it is. This is how much and how bad. This is the way we think of things. Stage, grade would be the more clinical names for these. So we can have tumors that are localized to the kidney. We call this localized kidney cancer. And we use 4 centimeters as an odd cutoff here. Why 4 centimeters? Well, we know a lot about the biology of these small things because over the last decades, CT scans and ultrasounds have been available to just about everyone for just about any indication. So we've got a huge uptick in the number of people being diagnosed with kidney cancer simply because we're finding these things when that gallbladder, appendix, constipation, or blood in the urine comes about in ways that we couldn't have done in generations past. And we know that these small or less than 4 centimeter tumors generally behave in a way that's not aggressive in the short term. 4 centimeters sounds pretty serious if it's sitting on the top of your head or dangling off your ear. 4 centimeters in your lung or your pancreas would be considered something serious in those contexts. We know that 4 centimeters in the kidney is something that makes us feel a sense of relief because we've got time to think about management. We've also got locally advanced disease. Locally advanced disease usually means that this tumor has developed some stickiness to it. It may have invaded into some local structures outside the kidney, very rarely into the liver, very rarely or less rarely into the lymph nodes or the major blood vessels that flow out. Metastatic disease is cancer that has left the barn, and the barn is the kidney. This is disease that has landed somewhere else. And in the kidney world, that can be the bones, the liver, the lungs, the lymph nodes out of the region, the brain, just about anywhere. This is disease that's more amenable to not having surgical type treatment, as I'll describe. Localized disease makes up the majority of new diagnoses, probably around 70 or 75% of these. We've talked about small and large before. The word surveillance may come as a surprise. When we see the word cancer, we feel the word action come up in our minds, and surveillance can feel like inaction. Surveillance can feel like a weight being forced on somebody. How can you talk about a tumor being inside me? I'll riff on this in a moment. But for small masses, it's actually an excellent management strategy in a lot of people when we balance the likelihood of this tumor growing, spreading, hurting, harming with the rest of the things that make up the challenges in our lives, whether that be age or other diseases. We've got the standard bearer called partial nephrectomy, which is a technically challenging operation to wedge out a tumor from the kidney in which it lies. Unfortunately, it's not like twisting an apple off a tree. It really is like trying to fish a blueberry out of a muffin and leave the rest of the muffin behind. Pardon the culinary puns here. It's technically challenging a thing, and this is where we talk about expertise and experience in the surgical realm. Open partial nephrectomies, which means a cut. You probably can't see me standing here opening my belly like that, but a cut to get access, usually for challenging, larger, more central ones inside the kidney where the action is higher. Laparoscopic or robotic keyhole surgeries for the smaller ones, the more peripheral ones that are basically out hanging off the kidney to be removed. And ablation, which you'll hear about soon. Ablation is an excellent way of managing the middle ground of tumors that we're concerned about, but also feel a bit wary about some of the more active treatments. And ablation is an excellent option for these. For the larger tumors, you'll talk about removing the entire kidney. Most of these are done through a laparoscopic approach these days. Laparoscopic means keyhole surgery, means removing the kidneys through a much smaller hole than we would having to have open things. That's the majority of these in this situation, but there are lots of reasons why an open surgery, which means, again, making a cut to remove the kidney, may be the right move. All of this just to sort of say, if someone says, yeah, you got a 3 centimeter renal mass on your kidney, you can feel that this would be incongruent for somebody to say, let's get the whole kidney out. And if they do, you want to close the loop on that information. This is why I bring this breadth to your table, so you can figure out what what range of things feels right. Of course, these aren't specific silos, as I say. When I think of silos, I think of grain silos being lifted off and the pools of grain smoothing. So there are humps that tell you what the right things to do on average are, but there's lots of overlap in these decisions. Locally advanced disease, as I say, has gotten sticky or spread somewhere locally and generally requires a larger surgery. If there's tumor inside a blood vessel leading in to one of the major vessels towards the heart, if there are lymph nodes nearby, those are not easily plucked out with the laparoscopic or keyhole techniques, generally require a bigger open surgery. These things generally also have a higher chance of rearing their heads again down the line. And metastatic or spread disease, we often want the call to action. As I said, the word cancer begets the word action. And sometimes that action is get this stuff out of me. And sometimes get this stuff out of me is not the right move. For decades, 2 decades, we thought that in people with disease that had already spread, perhaps in the lungs or the bones, that the correct answer for those who were fit was to remove the kidney, take the mothership away, and stop the signals from the satellites from being able to be read. And then we did a trial, and that trial surprised us by showing no real difference in most people who were a little bit sicker than the average in removing the kidney. And so now the call to remove the kidney has actually been superseded with the call to a bigger picture approach to the patient and perhaps treating with other elements. And that's where the word chemo comes from. Chemo is this great surrogate for what we call systemic therapy, putting things in the vein or putting tablets in the mouth to treat the disease from scalp to toes. The word chemo being so associated with this is problematic. Chemo is great for those who need it, but chemo has an image in your mind. When I said that word, everybody on this call, whether panelist or participant, has an image that comes to their mind. And that image is usually pretty similar. Feeling crummy, sometimes losing hair, sometimes throwing up, sitting in a chair. We don't use conventional chemotherapy for the most part in patients with kidney cancer. We use newer modalities called immune therapies, and there are some small inhibitors, we call them, that are taken by mouth. It's different. It comes with its own set of side effects, but often the best treatment for somebody with disease. And sometimes not doing anything right up front is the best move, even though we see there's something on the kidney and there's something somewhere else. Sometimes the best move is to sit tight and let things declare itself. That's what risk stratification is about. A piece of information that you ought to get out of your visits when you're thinking about things. What, if anything, do we have to do right now? What risks am I facing right now? How likely are things to get worse for me, and when? And that allows us to sort of target our decision making. Almost finally, we'll talk about surviving and survival. And survivorship, I mentioned this as these moments when you're left to yourself, where you don't have access to answering the questions, where you have the calendar showing you when things are going to start happening, when you have this history of having come through a surgery or suffered through another intervention that leaves its marks on you. In other domains, we sometimes call things like post-traumatic stress, and it can be that way for some people. For some, it's a niggling anxiety. For some, it's a worry about the future of the health, those around them. All of these things called survivorship. So a couple of notes on some of these sort of weird questions that arise here. I said surveillance a couple of times. Small kidney masses, sometimes leaving them alone is the right move if they're not likely to be destined to grow and spread. For some people with metastatic disease, sometimes the right move is not to pour in the immunotherapy because the balance of risks and toxicities is not best for you right now. And we do know that this is okay sometimes. Sometimes there's somebody who is 85 and they're not in good health. Age is not just a number, unfortunately. We are responsible for thinking, and you are responsible for thinking about health and energy and investment. But for the most part, if we can think that a small thing is very, very unlikely to manifest as a problem in the span of decades even, the right move is to say, time out. Sometimes surveillance is a long-term plan. Sometimes surveillance is a short-term plan, because you know what? I'd rather get through a graduation or a wedding or another large travel event or something, and surveillance is quite appropriate in these times. My only little bit of science here, my second only little bit of science here, is that we follow this horizontal line going through time. You're seeing 3 years, 4 years, 5 years of time out there. You're seeing 2 centimeters all the way to 2.5 centimeters. All this is really saying is that if you watch these small tumors And again, 2 centimeters ain't small if it's occupying your forehead, but on a kidney, it's small. They tend to grow very slowly, and this information makes us feel like a period of surveillance of watching is sometimes the smartest move to see if the threat actually does rise. And what if you're removing my kidney? How do I get by with 1 kidney? I was born with 2 for a reason. Well, 1 out of every 200 people wasn't born with 2, and they've been doing just fine. People give up kidneys for transplant recipients very commonly, and they often do just fine. Not to be glib, I'd rather have 2 than 1. But the concept of living with 1 kidney is actually generally not something that brings people to great harm down the line. An analogy I like to use is having 2 freezers, 1 in here and 1 here, and each of them has 2 ice cubes in it. In freezer 1, you open the freezer, you take out 1 ice cube, you close the freezer. You're down half your volume of ice. That's what a removal of a kidney or a nephrectomy is like. But the freezer's still functioning. The ice is safe in there, and it still works as well as it would do to cool a drink later on if you needed to use it. That's like a surgical removal. Doesn't imply a process that's harmful. If the plug goes out on the other freezer and you shrink both of those cubes down by half, you have the same amount of ice in the good freezer as you do in the bad freezer now, but the bad freezer is a problem brewing. This is medical kidney disease, and it's a different bird than surgical kidney disease. We always monitor, we always watch, but in general, keep it fed and watered. Water as much as you're thirsty to keep your urine going. Watching out for those simple carbohydrates and added salt to keep the blood pressure and the blood sugar in check. And a kidney generally will treat the majority of people as they need it down the line. Always exceptions, of course. And then the question is, how bad is it? That's what risk stratification really is. When we see somebody, we want to think, what's going on? Do we have the information we need to be reliably certain of the diagnosis without a biopsy, for example, with or without extra imaging? And then how likely is this to turn? Is this a threat to life now? Is it likely to be a threat to life in the future? These are the things that guide our decision. Yes to immunotherapy, no to surgery, yes to open surgery versus laparoscopic surgery. Here's how often we ought to follow you with CAT scans. These are the things where we think, and we're honestly not superb at guessing on survival. If I see a 2 centimeter renal mass, even a 5 centimeter renal mass, if it hasn't spread already, we really have no idea when that moment's going to happen. I wouldn't say no idea, but really not enough idea to reliably say you should be watched, you should be operated on. And so our surrogate for that is the surveillance approach to see if it misbehaves, and we get a bit more information about it to make our decisions. In the metastatic or spread setting, we do have numbers because we have clinical trials that show us on average how long people survive. But those averages are not super useful. There's my last bit of science for you here. The average can be what comes out of a trial, and I can say lots of people on average might have 5 years until this happens, 10 years till this happens, 12 months until this happens. But we know that people fall along these things called distributions, and somebody may have a lot longer than that, and we're dead wrong when we misinterpret that as saying the average survival is X number of years for this process. And unfortunately, some people have bad actor disease, and we underestimate things, or rather we overestimate things, and things are worse than we can. We give the averages with the caveat that people spread out, and we're rooting for people to be the positive outliers here. My final talk here is really about the follow-up scheme, and that follow-up scheme is about risk stratifying as well. How intensively do we have to follow you? Should I see you every 3 weeks? Should I see you every year? And so the questions we're thinking about here, how likely is this thing to come back if we've removed it through a partial nephrectomy or a radical nephrectomy? When is that likely to happen? Do we have information from the Mayo Clinic, from our own centers about who recurs and when? Can we use that to guide the intensity of our blood tests, clinic follow-ups, CAT scans? Where is it most likely to happen? Should I just be focusing on ultrasound on this kidney because that's where it's going to come back? Or does my data and my intuition tell me it may come back in the lung, and therefore I should be doing some chest imaging down the line? We have guidelines, mercifully, to sort of offload some of this thinking. We've had bright lights do the thinking for us, and we have tables that tell us roughly what to do. But you and we can think and can augment those tables as well. Then the bigger question here, when do I graduate? When do I stop this follow-up if I've had treatment for this disease? Our follow-up schemes end at about 5 years. I tend to follow people longer than that, but it's individual as well. Sometimes that golden handshake that says, I don't think we need to see you again, is a very sort of emotional and wonderful moment. And for some, a very anxiety provoking moment, which brings us all the way back to the very start, where we have to know each other. And that's the getting our sense of what we see about you from pixels on a screen and numbers on a blood test to the person in front of us, their health, their values. All of this allows us to help navigate things together. I hope you found this fruitful. I hope the remainder of your afternoon is an excellent one. And it's my pleasure as always to be able to participate.
Mike, thank you so much, Dr. Mike Leveridge. It's a sincere thank you for speaking today, because you really touched on many excellent topics, very patient-oriented topics. Good faith, good vibes, using our spidey senses, red flags, our fears, how we might feel. Wow, this was so pertinent to all of us. And I thank you for speaking to wait times too, because every single patient and caregiver suffers from the stress and anxiety on some level of the waiting. Sometimes we think it's the worst thing. And I certainly appreciate your acknowledging it and speaking to this side effect of having a cancer diagnosis. On a personal level, I'd like to thank you about speaking to active surveillance. I am one of those fortunate people that have been on active surveillance for many, many years. Unfortunate the reason why, but it's not for everyone, I must say, but it is certainly an excellent option for some of those kidney cancer patients out there. So thank you for bringing up that talk. I think Mona's joined us, and we have a couple of questions, and we'll do them really quickly. The first question that came early was would evidence-based decision aids assist patients and providers navigating their personalized cancer experience?
I think the answer is yes. Whether they can be constructed in a super reliable way, me writing out these slides and giving them to somebody is not a great amount of information. The way decision aids are constructed is a very specific way. Some of our friends at the University of Ottawa are leaders in this, and I think are working in this space. Decision aids are a unique thing that really aren't lists of information and a menu or a suite of options that you think might sound the way. It really is it has to tap into people's values about things. And I keep using that word, which sounds a little bit abstract, but different things mean different things to people. Just having a thing removed sometimes is palliating. Not having a big cut is important to some other people, and they're both very reasonable. And so putting these things on a scale, it's like going through your BuzzFeed or your Cosmo, what kind of golden girl are you sort of thing. You can figure this out, and it's a good way to pause and think. And then lo and behold, you may be surprised by the answer that you actually are probably the kind of person who would feel best with this. That doesn't mean you get what you get, but but I think a decision aid makes you feel like you're participating, gives you information in the gulf of in-between times while you wait. I consider it a positive.
Great. We did have one too. How does COVID affect wait times?
COVID probably hasn't had a dramatic impact on the wait ones. In fact, I think anecdotally, a lot of us are feeling like our clinics are 4 times as busy as they ever were because the threshold for telephone calls has gone down. And so I think the wait ones early on, when the world had shut down, everything was sort of in a panic. Once we got our groove on, the wait ones, I think, allowed us to talk to people. It didn't necessarily allow us to jump in and make recommendations as we might have on meeting number 1, but we can do a little risk stratifying. As I say, you want to look people in the eye. You want to see what they look like and what they are functioning like, because that goes a long way to your thinking around treating. But our ability get on the phone with somebody hasn't changed much from the ability to get in the clinic. And I would think I'm seeing a question about rural practice. I think in some of those cases, it it can actually provide some help because it can lower the thresholds to time of referral. Surgical wait lists, for sure. That's where this triage of priority 4 is, and it rolls off the tongue when I say 3 centimeter peripheral renal mass, priority 4. That's easy, but it means that somebody's got to wait. And when that person is a priority 4 and the priority 1s keep coming in and the OR times are lower, those priority 1s tend to never lose. The priority 3s and 4s are the ones that can get kicked down the road. So it takes a little bit of planning to say, no matter what, this person's getting my first operating day in March, come what may. It takes a little bit more thinking. So I can see delays to definitive treatment for the smallest masses.
Okay, great. Thank you. We'll just take one more question because we're already a little over time. Mona, I think you have a question.
Yeah, it's a question from Russell who's saying, do you feel rural GPs are able to quickly get initial referrals placed into the proper specialized treatment in kidney cancer centers?
It's an evergreen issue for rural life. The trade-offs between the bucolic splendor and the peace that one seeks, and the sense of community, and the ability to have their heart attack, stroke, kidney tumor managed locally and effectively. I think the telephone has decreased those thresholds. It's allowed us to have people not have to drive X number of hours to get places. Specialized treatment is always going to be relatively localized. Urologists and even more medical oncologists are going to be in population centers. Now, you'll have urologists just about everywhere, and some are exactly the person you're looking for a lot of your kidney cancer management. For some of the very more specialized things, robotic access, for example, the larger surgeries that tend to have oncology fellowships, it's probably a smidge easier to get those consultations right now, given phone things in network than it was. The problems with getting to the operating room are evergreen, and they always were. So I think with e-consults, for example, which are available for urologists, mopping them up if the wait times appear to be too long, all the way to telephone consultations. I hope that these barriers have meant that it's easier, if not neutral, for our rural friends who've delightfully chosen that wonderful way of being.
Okay. Well, once again, I thank you so much. Really speaking to the patient today and the caregiver with so many of our concerns, and many of the concerns that Mona and I get through our peer support calls. I know there was a few more questions that are not going to get answered, but if we have your email address, we will do our best to get the answers to those questions and get them to you in the coming week, okay? And thanks, Dr. Leveridge. It's so good to see you again. And
you as well.
I appreciate coming.
Take care. It's my pleasure. All the best.
Thanks.
And thanks again for all that Kidney Cancer Canada does, and best of the remainder of the afternoon.
Thanks so much. Take care. Bye-bye.